Hello, good afternoon, and welcome to this webinar. I am a IBD-focused gastroenterologist based out of the University of Calgary in Calgary, Alberta, and I'm very happy to join you this afternoon in my lovely office in the endoscopy suite to talk to you today about intestinal ultrasound for the diagnosis and monitoring of inflammatory bowel disease. Also useful for those who are symptomatic and need a diagnosis. Many of you are probably familiar with ultrasound. Maybe you yourself have been had an ultrasound. Maybe you've had a baby, you know someone who has. Ultrasound has not typically been used for the bowel, but for looking at other things like the kidneys, the liver, maybe even ovaries, prostate, and certainly the fetus. Why are we here today? Well, this novel way of looking at the small and large bowel is an increasingly transformational tool that we are adopting in clinic. And you may or may not recognize that access to this very important test is just probably a drive away. So today, what I'd like to do is outline really from scratch, what are the goals of therapy and why do we monitor your disease when you've been diagnosed with inflammatory bowel disease, either Crohn's disease or ulcerative colitis, and how together do we map out the ways in which to make you better. Secondly, I would like to talk to you about how intestinal ultrasound and this novel approach can be used to reach those treatment goals. And finally, I'd like to use some cases to demonstrate to you why ultrasound is changing the way we make decisions in clinic and changing your care. So let's start by just talking a little bit about treatment goals. When you've been diagnosed with IBD, Crohn's disease, or ulcerative colitis, the hope is that together you and your provider, either a nurse practitioner or a gastroenterologist or an IBD specialist, will really sit down together and map out a path forward. And on that path really are a number of different goals. There are goals that are important to both of you that should be achieved, and generally a time frame in order to achieve those. One of the first and most important goals that we hope to achieve is to improve your quality of life and make you feel better. So symptom control and quality of life are of incredible importance to us and obviously to you. Things like being able to ride a bike, being able to go to the grocery store, being able to work, go to school, sleep through the night and not be fatigued, maybe even be intimate with your partner. These are all elements that are incredibly important in quality of life. The second is the normalization, basically, of your blood work and maybe your stool tests, which we'll talk about. The third is the normalization of your scopes or the pattern of your endoscopic findings, which we will also talk about. And then lastly, we have increasing recognition of the value of what the bowel looks like in cross-section and healing of the bowel transmurally or in cross-section. So we're going to talk about all these treatment goals and how they meld together to ultimately put you in remission and make you feel like you can live your fullest life. So we've talked a little bit about treatment goals and what those goals look like when we think about the tools in which to reach those goals. So let's just dive into some of these different tests. For sure, symptoms are incredibly important. And there is a huge range of symptoms. And I will tell you, some patients have severe disease and not a lot of symptoms at all. We see severely inflamed, for example, terminal ileum at times, and patients really don't report anything at all. On contrast, when patients have inflammation of the rectum, they sometimes are disabled by stool frequency, terrible urgency, the need to run to the toilet, cramping of the rectum, pooping at night, pooping multiple times during the day, and there's all sorts of symptoms in between. But one of the first things we try to understand when you come to see us is how you're feeling. And this can be a whole range from the upper GI tract to the lower GI tract to symptoms outside of the gastrointestinal tract, including joints, skin, eyes, even liver and kidney are important. What about blood? Blood tests are really important, and we can get all sorts of important information from your bloods, starting with your complete blood count. This gives us a sense of whether your hemoglobin is low, your white blood cell count is elevated, or your platelets are elevated. All of these have different meanings and different implications. We can also measure very important nutritional stores like iron. Iron is necessary to make blood, to make hemoglobin. When you're losing blood, even if it's hidden and you don't see blood in the toilet, for example, you can become anemic or have low hemoglobin, which can contribute to fatigue. So we see sometimes low iron stores in active inflammatory bowel disease, a measure very importantly drawn from blood. Other nutritional parameters we measure, like vitamin D, vitamin B12, even vitamin A and zinc. We look at your kidney function, your liver function, and very importantly, we look at inflammatory markers in your blood, namely C-reactive protein or CRP. This is accurate in about 2/3 of cases. So in about 70% of individuals, it will reflect inflammation that's going on in the gut. And in about 1/3 of patients, it just doesn't tell the truth. It can be falsely negative. We see this often in ulcerative colitis, even in fibrostenotic Crohn's disease. So we can't sell the farm on the CRP. It's just one test. And we have to recognize when it might be falsely positive, for example, if you had an infection, or falsely negative. It just isn't indicative of your disease. We do stool tests more and more often at different intervals, specifically fecal calprotectin. We also test for stool-based infections to make sure that you don't have an infection that's driving your symptoms, like Clostridium difficile, a very important infection we need to rule out. Fecal calprotectin is a reflection of the presence of neutrophils or a type of white blood cells in the stool that secretes a protein that we can detect and is a very accurate measure of inflammation. We put all of these tests together collectively as biomarkers. I'm sure many of you who are listening to this webinar have had a scope before and had the wonderful pleasure of drinking liters and liters of prep. This isn't an easy test to do. You have to come into hospital, you need sedation, you have to take the day off and the day of the procedure off. This is in order to clean the colon and the small bowel out of residual food and stool so that it looks just like this, nice and clean. Not easy to do. The image on the left where my pointer is the cecum, or the end of the right colon on the right side. This tiny little opening is where the appendix comes off. And this circle here is the ileocecal valve that joins the small bowel. If we pop the scope through the ileocecal valve, you can see the terminal ileum, and you can see it looks almost just slightly rough. You can see the tiny, tiny, tiny little villi if you stare very closely. Those villi are finger-like projections, and they're the workhorse of nutrition. This is where our nutrients are absorbed in the small bowel. This is also where Crohn's disease occurs. So colonoscopy is a very useful test. Sometimes we do gastroscopy too, in order to look inside the bowel. Now, we've talked about symptoms, biomarkers or blood tests, stool tests, as well as endoscopy, but that only gives us part of the picture. We also do cross-sectional imaging so that we can look at the bowel in cross-section. So the bowel actually has 5 layers. So we need to see each of those layers and understand which are effective. Crohn's disease, for example, affects all layers and can even result in penetrating complications outside of the wall of the bowel. So this image really depicts how we see things and the limited advantage that we might have if we only use one test. and the importance of combining tests in addition to how you feel in order to understand your disease. So how do we do that? As I mentioned, we look in cross-section. So look at all the rich information you glean when you divide something in half so you can see it in cross-section. You see the richness of the donut, you see what's in the styrofoam cup. It's the same thing when we do a CT scan or an MR enterography or even an intestinal ultrasound. We look at the bowel in cross-section, and we look at the very important mesentery that surrounds the bowel, both of which we cannot see on endoscopy, and we do not get an appreciation for with blood work alone. And your symptoms certainly can be from a myriad of things that don't necessarily reflect what's going on inside your bowel. Here's an example. So this is small bowel. Here's the kidney in the very low pole, and you see the contents swirling, contents. These are all loops of bowel that we're looking at end on in cross section. And this is muscle here. This is the psoas. Here we see a stricture. So here you see thickened bowel with the different layers. You see the different stripes, black, white, black, and you see contents shooting through these two areas that are about, maybe an inch long, where the lumen is narrowed and contents are having to shoot through. Behind it, the bowel is dilated, working very hard to get the contents through. So here, in a very short period of time, we can see the mesentery around the bowel. We see the bowel and the stripes, or the echostratification. We see how hard the bowel is working to get past the stricture. And we see the layers of the wall of the bowel. When we think about ways in which we decide if a test is a good test, we think about test characteristics. And so when we're going to introduce a new test to you in your disease management, there's a number of measures that we have to consider in order to say, yes, this is a test we should invest in. This is a test we should offer patients. So there's actually a very rigorous evaluation of tests in order to bring them to the bedside to you. And those are as follows: the 3 A's: accuracy, acceptability, and repeatability goes with acceptability, access or availability to the test, and then how much the test costs. So let's go into some of these details further. The first one is accuracy. Well, it depends. Accurate compared to what? We have to compare the test results to all sorts of different measures to determine whether or not it's accurate. So when we compare it to symptoms, certainly we know that one of the problems with measuring symptoms alone is that sometimes there's a disconnect. Sometimes patients have lots and lots of symptoms and no disease activity. And then the opposite is also true. They have lots and lots and lots of disease activity and no symptoms. And that's because the gut is very complex in how it senses disease and function. So different people have different experiences with their gut. So the accuracy of using symptoms alone as a measure of disease activity is limited. It's still important because it affects your daily function. It affects your ability to enjoy your life, but it isn't always a reliable measure of disease activity. So when we measure ultrasound activity compared to biomarkers, compared to endoscopy and other cross-sectional imaging modalities, we have more and more evidence all the time to reflect that it adequately and very accurately, similarly detects disease. Here's an example. So in the left-hand panel, you see 2 rows of stripes. This is the sigmoid colon that's collapsed. And you can see lots and lots of red and blue pixels. That's blood flow in the wall. The big circles are actually blood vessels. But within the wall, you see lots of disease activity. The wall is thick. You can see the layers, but there's lots of blood flow. Similar to that, a different vantage, so a different lens, is an endoscopic view. Here we have the sigmoid colon, and you've got large, deep serpiginous ulcers. that reflect how the sigmoid colon looks on endoscopy. So where's the value here? You see both. Here's another example. This is an ultrasound image of the ascending colon. You can see the wall is very thick. It looks white because it's chronically inflamed. Sometimes this occurs and we can't get any farther because the scope loops, or we have difficulty getting into the terminal ileum for all sorts of reasons. Sometimes it's even narrowed. So you have this image in cross-section of the cecum. And then here on the right-hand side, you've got an image of an MR image, and you've got mesenteric inflammatory fat. You have a normal colon, but a terminal ileal stricture. And you don't see any dilatation behind that narrowing. So the red arrows show thickening of the wall of the bowel. We know that ultrasound correlates extremely well with both MR and CT as measures of cross-sectional imaging. What about the second A, which is acceptability? One of the most important parts of accepting a test is what you'd prefer to have. Many of you who've had 4 liters of cholite in a colonoscopy, having to take the day off to prep and take the day off to have the procedure, know that this is a hugely impactful test on your everyday life. Having a test where there isn't preparation, you can just do it while you're seeing the doctor anyway, so you don't have to spend the money on another parking ticket, another appointment. You can do it all at once, might be preferred. Other aspects of acceptability include repeatability, whether there's preparation, how tolerable the test is. Does the test cause pain? Does it cause discomfort? Do you have to get an intravenous? Do you have to drink a liter of negative contrast like you do for an MR or a CT? So the overall experience reflects whether or not the test is both repeatable and acceptable. And the hope is that all of this is easy for you and at the same time yields really important and accurate information about your disease activity. Access is really important. MR is a great test and it depicts the bowel beautifully. It's not easy to access though, and a routine MR enterography to evaluate the small bowel in many centers in Calgary can be up to 6 to 12 months. The reason for this is because it's a very expensive test and the wait times are long. If we had access to ultrasound while you were seeing your provider in clinic, it would basically kill 2 birds with 1 stone, or you could get access to a test where you were having a follow-up anyways. So wait times and access are very important. When we look across Canada, there are more and more academic centers providing intestinal ultrasound every single month the notion it has evolved. So from the West Coast, Vancouver, all the way to Halifax, there are more and more centers where it's available. What about cost? When we think about cost, there's lots of aspects of cost. When you have to come into the hospital to have a test, there's all sorts of costs that are involved, from the technicians that are responsible for administering the intravenous contrast, to the MR machine itself, to the endoscopes and the nurses that provide care for you in hospital. We have to incorporate all of these costs into cost effectiveness. There aren't a lot of studies that have been published to date looking at cost and the cost utility of intestinal ultrasound, but we are collaborating with the Institute of Health Economics in Edmonton to do a robust economic utilities study in order to look at this in the province of Alberta and then extrapolate it across Canada. We believe, because ultrasound itself is repeatable and easy, and it's just your provider performing the test, that it will be cost effective. And there's lots of other jurisdictions that have shown that, like the UK and Italy, but more studies are needed. How would we implement intestinal ultrasound, and what other interesting and important aspects of the bowel would we add to the evaluation? Well, certainly one is bowel function and bowel motility. Here's another example of an obstruction where we can put the ultrasound probe on the tummy and see immediately that the bowel is dilated and is swirling and swirling and swirling the contents. When people feel bloated or have pain, and we can do an intestinal ultrasound and it's normal, this is altogether reassuring. We can see the bowel in cross-section, and we can see that the function is actually normal. We need other probable measures, maybe even artificial intelligence, to help us understand when the bowel function is only slightly abnormal. And this is another way in which intestinal ultrasound might add value, because it's one of the only tests that we can look at motility in real time while you're watching the screen with us. How would we bring this into your care path? Well, for sure, once you've had a colonoscopy and you've had a diagnosis of ulcerative colitis or Crohn's disease, or you're symptomatic, and we want to understand whether you need to have a colonoscopy in order to get a diagnosis, you would come to the clinic and we would do blood, stools, make sure you don't have an infection, and listen to your symptoms. Then we can do an ultrasound and comprehensively look at your entire bowel. If you don't have a diagnosis yet, and all your bloods, your stool tests are normal, and your bowel ultrasound is normal, then maybe we would take a step back and say, let's try some conservative measures. Let's say alternatively that we can see inflammation on your bowel ultrasound, your fecal calprotectin's up, your CRP is up. We can then expedite your colonoscopy. To get a diagnosis of inflammatory bowel disease, we will always need a colonoscopy because we need tissue to look at under the microscope, so we have histologic evidence of disease. With that, we can then follow you at different intervals to see whether the therapies we implement work. So let's say you get a diagnosis of Crohn's disease in the ileum, we have tissue, we do an ultrasound, we have a baseline set of measures, we start you on effective medical therapy. We would then 3 months or 12 weeks later, follow you up to make sure you're getting better. And the first thing we would do is an ultrasound. We can look at your CRP and your fecal calprotectin for sure, but we want to see whether that wall of the bowel has shrunk in its thickness. We want to see whether the blood flow is improved. We want to see whether the mesentery is less active. Then again at 6 months and potentially at 12 months. Now, it's currently recommended to have a scope at about 9 to 12 months. And could we replace a scope in many circumstances for an activity measure? We certainly could. And we can replace MR and CT as well. There are certainly circumstances where the disease is complex, it's very long. We need to make sure there aren't multiple loops involved, or maybe there's penetrating complications. Then we need a CT or an MR. And these tests are complementary. There's also circumstances where we can't get around having a colonoscopy. For example, when you need colorectal cancer surveillance, that is a crucial test. If you've had ulcerative colitis, for example, beyond the rectum for more than 8 years, we need to do colorectal cancer surveillance. And there are all sorts of risk factors you would speak to your provider about that would determine the interval for colorectal cancer surveillance. For just doing a colonoscopy for activity surveillance to look at whether or not the drug is working, then we can absolutely potentially replace colonoscopy, CT, and MR with intestinal ultrasound and biomarkers. We can do the same thing in ulcerative colitis, and ultrasound is used more and more for both the diagnosis and monitoring of ulcerative colitis. Here's an example that we just saw on endoscopy, and here you can see it in cross-section where the bowel is very straight. It's lost its folds or the haustration, and there's mesenteric inflammation as well, and the wall is thickened. If we were to put some color Doppler on here, it would light up as well. So when we think of all the things we've talked about today, it's a lot. We've talked about treatment goals and how important it is to sit down with your provider and map out what we're trying to achieve together by introducing effective medical therapy for your IBD. Where are we going together? Where does this road lead us? It leads to symptom control, biomarkers, CRP fecal calprotectin normalization. Very importantly, we want to see your bowel heal. And we can see that either on cross-sectional imaging and or endoscopy. And maybe we can reduce the cost and the invasive testing by using more intestinal ultrasound to both establish the extent and severity of your disease and to follow you up to make sure you're healing. We believe this is a cost-effective, more acceptable or tolerable tool that we hope to bring to more clinics across Canada as time goes on. We have to advocate for it. We have to train docs. We have to bring ultrasound machines into clinic, and we need to make sure that docs are remunerated for their time in the provision of this very important tool, all of which we hope and will continue to measure the improvement in your care. So what do we look at in the next 5 years? Well, we look at really a transformation in the provision and monitoring of care for inflammatory bowel disease. And we hope that you join us on this road to the future where you have more and more access to this very important non-invasive tool. I very much appreciate your time in listening to this webinar, and feel free to reach out to us anytime if you have questions or concerns, or you want to find a clinic near you where you may have access to intestinal ultrasound. I wish you the very best in your journey, either with symptoms or with IBD, and we will see you soon here. Take care.